Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Daniel Johnson. He's a pediatrician. Today's Kevin MD article is From Isolation to Innovation, the Power of Learning Communities in Healthcare. Daniel, welcome to the show.
Thanks a lot, Kevin. Appreciate being here.
All right, so tell us a little bit about your story and what led you to write this article in Kevin MD.
Sure, thanks a lot. So I'm a professor of pediatrics at the University of Chicago. I've been a general pediatrician very early in my career, but nearly all of my career, I've really been a pediatric infectious disease specialist and, very importantly, a program builder, with my programs focused on capacity building and workforce development, with the goal of increasing services for underserved and under-resourced communities. That first was focused on HIV, then I focused on communities on the south and west side of Chicago, and now my work has moved beyond those geographies as well. I think probably the most important thing about me is that I'm a native Chicagoan. I grew up on the southeast side of Chicago. I was raised in a Jewish household, and the Hebrew term, are you familiar with it? Tikkun olam?
I'm
You ever heard of that?
No.
So it means healing the world or repairing the world. And it's really about social action and the pursuit of social justice. You know, the goal that we'll all work together through ethical behavior and positive change to make the world a better place. And that was really heavily emphasized during my youth and my years of entering into my career. And so that's really what has led me to the place I'm at. You know, from the article that I started as an engineering student, thought I wanted to do automotive design. But then I took a class on transplant materials, got interested in biomedical engineering, got advised to go to medical school, and there I discovered the joys of medicine and direct care of children and family. I mean, taking care of kids, it's fun.
Yeah.
You know, you can really goof around with them, but you get to see the joy of children and their recovery. So my background led me to ask a lot of questions, and that's really what led me to develop what is now Echo Chicago, or a Project Echo program. And I'd be happy to tell you more about that if you like.
Yeah, absolutely. So tell us about Project Echo and your Kevin MD article for those who didn't get a chance to read it.
All right. So, you know, back in 2009, I first learned about this Project Echo program. In fact, it's kind of funny. A friend of mine went to Truth or Consequences, New Mexico. I just love that name. And in Truth or Consequences, she was talking to a friend, and she was telling her all about this program called Project Echo. And when that friend of mine got back to Chicago, she told me about it, and I contacted Dr. Sanjeev Arora, who was leading the program, and he said, come on down to Mexico. New Mexico, not New Mexico. Come down to New Mexico, and I'll teach you what I'm doing. And, you know, he was focused on rural New Mexico.
Mm-hmm.
And what I could see was that this could be applied to urban America, and in particular to Chicago. So what is Echo? Echo is recurring sessions. They're roughly an hour long. So it's a small amount of learning that occurs frequently. In our case, we do them weekly. And, you know, that's really how you're supposed to eat. But it's also what learning theory says you should learn. And it's done in a group setting with some didactic, but it's heavily focused on case-based learning. And the success of Echo led me to focus on why it's been proven to be one of the strongest tools for medical learning. And it's really about sharing data-driven information, sharing experience through case-based learning, and coupling it with active listening and participation. And that should sound familiar to anybody who's a doctor, because that's basically what rounding is. Mm-hmm. Anybody who's watched a doctor show gets to see rounding, but of course we live through it. And we know that people can't learn everything from a book. I mean, think about how we learn to drive, right? I taught my kids how to drive. Would I have been happy with my kids just reading a book about how to drive and then just go out there and drive? Mm-hmm. No, of course not. They needed to learn under the tutelage of someone who could give them direction, ideas. Well, that's what rounding really is the opportunity to do that. But you know, with driving, it's a static process, right? Once you learn to drive, you really know how to drive. Yeah. but not with being a medical provider, right? Medicine is constantly evolving. And so we need to constantly be learning. And what ECHO is an all teach, all learn, all support system for knowledge transfer. And it's good throughout a person's career, not just during their training. And I wanted to share that thought, and that's what led me to write the article, because it's important that we not stop that process of rounding and learning when we finish our training, which is how most medical providers, their career evolves, is they go out into practice and they don't get that opportunity to participate. And that's what we've done with ECHO, is we've brought that opportunity to them. And you know what? It makes a difference. ECHO has been proven to reduce cost, increase quality of care, improve provider and patient satisfaction, and even help to build communities. By keeping patients local, it helps to strengthen communities. And by keeping providers happy with their job, they stay in those communities. So it strengthens both rural and urban neighborhoods. And it needs to be part of the ongoing process of people's careers. And the medical education system needs to recognize that and support it. So I wrote the article.
So tell us what a typical session would look like for a practicing clinician.
Yeah. So, usually there's somewhere between 20 and 30 people who are willing learners. And the sessions are led by facilitators, subject matter experts. They last about an hour. We do them weekly. We pick a time that works well for the group. In truth, most of the time that's 8 o'clock in the morning, because that's when providers have some control over their day. And the beauty of it is that you get on a video conference setting just like this one.
Yeah.
So all the time is spent learning rather than travel or coming together. And because you can do it frequently, again, learning theory has taught us that people learn best when they learn small amounts frequently. And that's what we're doing with that session. And the first 20 minutes are usually didactic, so helping to build foundational knowledge. And the remainder of the time is case-based, HIPAA protected, so that way there's no personal health information shared, but providers bring their cases. So it's real world learning, and they share them, just like rounding. And then there's a conversation. And you probably remember from rounding that it wasn't just the attending, the most senior person in the room who was sharing knowledge. It was everybody.
Yeah.
And that knowledge comes together to produce a plan for the care of patients. And in this way, it builds capacity, it expands the workforce, and increases the availability of services at the community level. We did it in our training in a hospital setting. This is being done at an outpatient setting almost exclusively. And the goal then is to strengthen the outpatient care so that way patients can stay in their medical home, don't have to leave their community for care, and are able to get high quality service at their place close to home.
Now, what kind of topics or specialties are typically offered?
You name it, we may have done it. I mean, we've done over 50 different topical areas. So when we first started, we started with resistant hypertension in adults. But I'm a pediatrician. So I then said to my partners in this, because we use the cues from the primary care providers out in the community to tell us what they need. I said to them, what about pediatrics? So that we then did obesity and ADHD. And then we've expanded. So we've done focus on just patient type. So adolescent medicine, geriatric, women's health. We do very specific diseases like ones I've already mentioned, but add to it like hepatitis C, diabetes. So there are so many different topical areas. But what's critical to the topic selection is that it needs to be of major concern to the provider and to the patient population that they're taking care of. It should have public health consequences, and it should be teachable through an algorithm or some type of protocol. So that way those primary care providers can follow and learn a protocol and algorithm that will help them deliver the care that their patients need. It
So,
also builds community
mhm.
because now these providers who are often isolated in their own practices come together and meet each other remotely, but they develop relationships. They also develop relationships with the subspecialists, the subject matter experts who lead the sessions. And so now you've got this community that grows, helps to combat professional isolation and build a team that can provide the care that patients need.
It almost sounds like a virtual grand round, so to speak.
Yeah, you could really say that, but it's much more heavily focused on the interaction
Mm.
between the learners and the subject matter experts.
Now, is there CME offered for these sessions?
Oh yeah, the CME is offered, but what's interesting is that only about half the providers actually access the availability of the CME, which I've always thought was kind of interesting. But it just shows how satisfied they are with the opportunity and how that is driving them to the table over and over again to want to do this.
And what is the cost, if any?
We don't charge. We've made that a rule of thumb. So how do we underwrite it? I mean, that's always been the challenge. Now, our ECHO program started in 2010. So we've been funding this for 15 years. And we did it originally through some internal funding at the University of Chicago. We then found foundations who felt like this was a great way to support it, then federal money, city and state money. And that's how we have done this year after year. But it's part of the reason why I feel like we need to incorporate this into the medical education system so that medical education system will support this. And it's the reason why the article in part focuses on introducing the concept of echo during people's education. So that way they will come to expect and want it and demand it after they finish their training because of the strength that echo will bring to their practice.
Now, if I'm a physician listening to you for the first time and interested in taking the first steps and participating in an echo session, what are some initial steps that they can take?
Well, you need to identify an echo program. I mean, there are over 1,500 echo programs around the world now, and most of them are in the US, and almost every state now has echo programming. Part of the reason why it's best to join an echo program in your own state is because there are unique aspects of care that relate to how care is delivered in your locality, in your geography. And although we do, for example, our program does nationwide echoes on occasion, most of our echo programming is directed at people in Illinois because of some of the unique aspects of care delivery in Illinois having to do with reimbursement, rules of the road, so to speak, that need to be appreciated and followed. But of course, there are aspects that are applicable no matter where you're at.
Mhm.
But first, you got to find that echo program. Then look at the list of what they're offering, or even contact them and say, can you develop an echo program in a particular area? When I first started, I wanted to focus on hepatitis C. I'm an infectious disease specialist. But my providers in the area said, no, 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 we're not interested in that. But 3 years later, they came back to me and said, please develop a program in
Mm.
hepatitis C because we now recognize the pandemic around hepatitis C and we need help. And, we went to the CDC. They provided funding. We did a 5-year project that trained over 350 primary care providers and made a huge difference in the availability, diagnosis, and treatment of hepatitis C in the Chicagoland area, something that we proved and published after doing that project.
We're talking to Daniel Johnson. He's a pediatrician. Today's Kevin MD article is From Isolation to Innovation, the Power of Learning Communities in Healthcare. Daniel, let's end with some take-home messages that you want to leave with the Kevin MD audience.
Yeah, well, thank you for that. And I would say that my biggest lessons learned is first, never give up. One person can do a lot, and so it's worth working hard to do that. But one of the big lessons I've learned is that a team can do even more. And, I've built a team around this echo concept. And, we believe in the all teach, all learn, all support model. And that really has proven to me over and over again that teams make a difference, that bringing people together for learning is critical. The other is that we need to be committed to repairing the world through our actions. It's in essence making the world a better place for ourselves and others. And finally, I guess what I want to say is that we have to all work now to rebuild the system that our government unfortunately has worked recently to dismantle. We have to rebuild the faith of people in science and in medicine and in the medical community. And I believe that the sharing of knowledge, the democratizing of knowledge, the movement of knowledge is key to making sure that we're able to do that.
Daniel, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thanks a lot, Kevin. Appreciate it.